I am Sarah Russell. I have been a nutritional therapy practitioner since 2013, and I'm really excited to be here doing this webinar alongside Marianne, who is the founder of Lab Smarts, um, to talk about blood work interpretation during preconception, pregnancy, and postpartum. Um, so I just wanted to say a few things about myself. I run a private practice where where I see clients one-on-one for preconception, pregnancy, and postpartum concerns, as well as complex health cases. And it was in the course of supporting clients for during pregnancy that I realized, looking at their blood work, that a lot of their lab reports flagged things when they were actually clinically very healthy, and the things that were flagged didn't make sense. So I started looking on PubMed to understand, do white blood cells and neutrophils raised during pregnancy? How do liver enzymes change during pregnancy? Is there a difference between, one trimester to the next? And lo and behold, I noticed that a lot of things do change during pregnancy, and that healthy pregnant people have vastly different labs from non-pregnant people who are healthy. So I was really excited when a colleague and mutual friend, Victoria, introduced me to Marianne, and we had no idea what was going to be born from this collaboration. But once we started talking, it became obvious that we both really wanted to create a course to train practitioners on how to properly interpret lab work during pregnancy, and the collaboration with Lab Smarts has been amazing because of the software. And I will let Marianne speak to that herself and also introduce herself.
All right. Thank you, Sarah. Yeah, I'm so lucky to have met you. My name is Marianne Marks. I am the founder and creator of Lab Smarts, the software. I left my corporate job many years ago and went to Bowman College, got a nutrition consultant certification, but I'm a techie person. And so when they introduced blood work, I just loved it. And I started making it on a spreadsheet and then automating it. And I thought I should create a software to help myself and my colleagues out with interpreting blood test results. And I'll talk about ranges and how it couldn't all just be done in the software. And so I created this software, and like Sarah mentioned, I had a few reference ranges in there for different trimesters of pregnancy. But then when I met Sarah, she's like, I've done so much research already, and there's so many different markers that change throughout pregnancy. And we just decided to start working together and doing more research. And we have like at least over 100 different markers in the software now that we adjust for different trimesters of pregnancy, because it's just so drastically different in each trimester. So I'm happy to be on this webinar with Sarah and be working with Sarah. And we'll talk a little bit about now our course and how we picked some of the coolest slides from our course, and I'll show you here to show you and just give you it at a high level. I mean, our course is like 6 weeks for 2 hours each. So there's so much more that we could show, but we're going to show you some of the cool stuff that we created, and hope you learned some things here. So you're in the right place if you frequently work with clients during preconception, pregnancy, and or postpartum, during lactation, with or without lactation. We'll talk about that. And blood markers are different throughout if you're breastfeeding or not. Or if you review blood work and sometimes have a client who is trying to conceive, trying to get pregnant, or is already pregnant, or has recently given birth. You're going to be amazed how much the blood work changes. If you want to improve the quality of maternity care, we have a lot of midwives and practitioners using in our course. We did a live course last year, and we have a evergreen course that we've recorded, but we're doing this other new live course. But people using the software, people learning more in maternity care about how the blood work changes so much during pregnancy. And if you're a passionate just about women's health in general, work with female clients of reproductive age, you're going to want to know this information, because every client that comes to you has some blood work probably already that you should be able to take a look at and understand at a high level. We're not diagnosing, and that in the software, because I'm a nutrition consultant, in the software we don't have any diagnostic terms, so we're not trying to diagnose or get in trouble for diagnosing, but we're just trying to point out imbalances, and that's what these range adjustments do for us, is to get us a little more accurate to identify those imbalances. And then stay tuned to the end, because we have a very special offer, and we'll open it up for questions. So after this webinar, you'll be able to identify overlooked preconception markers and why to run blood tests before conception. You want to get those nutrient levels right and some things taken care of before your client starts to try to conceive. Then you'll be able to differentiate between conventional, functional, or optimal ranges, bioindividual reference ranges, and then evidence-based pregnancy-specific reference ranges. Well, I'm sharing my whole screen, so it's going to, everybody sees that. Yep. And then also you'll be able to understand some of the mechanisms that change the composition of blood in pregnancy and postpartum and their impact on blood markers. So in the course, we go through different physiology of why the blood changes for different markers, and we'll touch on some of that here. First off, though, at a high level, there are differences in reference ranges. So probably most of you on this call understand the conventional reference ranges. Let me show. Can you see this too? Am I recording this little video of us? Let me shut that down. So there are conventional reference ranges. You know, those are the ones you get on the lab report, like LabCorp Quest. They're called reference ranges, reference intervals, or normal ranges. You know, sometimes you hear, oh, you're in the normal range from your conventional doctor, but we know that, you know, those aren't normal. They're based on just and the reason they say normal, because they just take 95% of the population, do a standard statistical like, what's it called? Normal distribution, Gaussian. So we could get into statistics, but so then that's 2 standard deviations from the mean, and they just call that normal. But we know that most people who go get their blood work done are going because they have some sort of issue. So you don't want to fall in the upper and lower ends of those lab reference ranges. And that's where optimal or functional reference ranges came in many years ago in the you know, alternative health space, where they did kind of just taking, you know, because the lab ranges are 2 standard deviations from the mean, you could take 1 standard deviation from that mean and get a little more accurate. There was some, we call him like the godfather of blood chemistry analysis, Harry Eidner. He did a 10,000 patient study to try to come up with some better optimal ranges. And then I've taken so many blood chemistry courses, and one of them really pointed out and backed up the different optimal ranges by different studies. So in the software, I use mortality or disease studies. So there are studies where they say, you know, if your marker is over X, GGT's over X amount, you are more likely to, you know, die or have some sort of disease. Or insurance, like life insurance companies do different studies too, where same thing, they use GDT. That's a good one. If your GDT is over this amount, they may not give you life insurance. So there are good studies out there to make the reference ranges, optimal ones, even more accurate. And then I take it one more step further to make it even more accurate and more personalized to your client, is where I adjust reference ranges based on the different traits of your client. There are different reference ranges for different age groups between male and female. Younger men have different blood, their blood looks different than older men. There's some markers in the software I adjust for different ethnicities. And this one's a cool one, elevation. I adjust people living in higher elevations. The barometric pressure up there is less, so they're breathing in less oxygen, so the body overcompensates by making more red blood cells. So you can't really compare, and the lab reference ranges on LabCorp and Quest, they don't adjust for high elevation. So those are just sea level ranges. So you can't compare somebody living in a higher elevation with their ranges to somebody living at sea level. There's also adjustments for menstrual phase. If you're looking at sex hormone markers in the blood throughout the menstrual cycle, They look different in each phase of the menstrual cycle. And then a little bit adjustments and differences in menopausal status for some markers. But then the most abundant markers that change are the ones that with throughout pregnancy trimesters. And even in each trimester, they change pretty drastically. So I already mentioned, I mean, there's at least over 100 markers. I have 118 in the software, but at least more than all of them, I have different reference ranges for different trimesters of pregnancy. And as I continue to add more markers, that's something I have every time is adjustments for each trimester of pregnancy. So Sarah will talk a little bit about preconception.
Yeah, thank you so much for that amazing introduction, Marianne. I also wanted to let everybody know that we are going to do Q&A at the end. So please feel free to chat your to type your questions into the chat. But we keep in mind that we will be reading those and answering them at the end, just to keep distraction low. Also make sure that you're not accidentally turning on your microphone or video until the Q&A session starts. So let's start with preconception. We're not really talking about lab markers that change during preconception, but more because, of course, preconception things haven't yet changed as a result of either pregnancy or having given birth. But we are wanting to be aware of specific lab markers that we want to see in our male and female clients. Remember, the male partner is significantly important in contributing to a healthy pregnancy. So what are these markers, and what are the factors that we want to be aware of? So consistency is really important. Time of day, the season of the year, the phase of the menstrual cycle, fasting patterns such as Ramadan. If you have a female client who is intermittently fasting and trying to get pregnant at the same time, maybe to have a careful discussion with the person and consider having the individual reconsider that, unless there are compelling evidence-based reasons why they are intermittent fasting, because it could actually mess up their hormones in the long run and might make it harder to conceive. Strenuous exercise in the past 48 hours can change a number of markers. Lab consistency and patient context. When you have a female client who exercises very strenuously on a regular basis, you want to make sure that you are extra careful of iron markers, because anemia is more likely in female clients who exercise strenuously. So we want to see those markers in male and female clients regardless, but all the more if somebody has this pattern with exercise. Can you move to the next slide, please, Marianne? Thanks. So why do we want to run labs during preconception? Nutrient levels in both sexes affect hormonal status, sperm and egg health, and conception outcomes. In females, nutrient levels before conception affect maternal and fetal outcomes, and we can work to prevent spina bifida. Preconception labs allow you to establish a baseline result for the individual patient. This is really helpful in helping a couple get pregnant in the first place. Can you move to the next slide, please? Thanks. Female preconception markers that we absolutely want to look at are nutrients, including vitamin B6, often forgotten, B12, folate, homocysteine, retinol, which is an active vitamin A marker, vitamin D, iron, zinc, and copper. When we're talking about iron, we are talking about not just serum iron, but we're talking about a complete blood count, iron, ferritin, transferrin saturation rate, and total iron binding capacity. Those are all important for context. Sex hormones, not everybody will need all of these, but in cases where there's an issue with infertility or some kind of pattern where there's a concern with hormonal imbalance, some of the markers you might want to look at hormonally are LH, FSH, sex hormone binding globulin, prolactin, estrogen, progesterone, and AMH. You also want to make sure that when you're running sex hormones, that you're counseling your patient to run them in times of the month when it makes sense to run those specific markers. So for example, if I'm looking at FSH, LH, and estrogen, maybe alongside some of these others, I definitely want to have my client run those around day 2 or 3 of their cycle versus, some random time of the cycle, because the result is going to be more useful. Big picture wellness, complete blood count with differential comprehensive metabolic panel and hemoglobin A1C. These are really important markers for everyone. Let's move to the next slide. You want to make sure that you don't overlook retinol, which is vitamin A, the active form of vitamin A. The potential to convert beta carotene to vitamin A varies drastically from person to person. Retinoic acid signaling pathways regulate gametogenesis. So basically the ability of the gametes to do their work and fertility, and they may play a role in the pathogenesis of PCOS. So very, very important pathways. Retinoids help regulate embryonic development, vision, metabolism, and reproduction. The corpus luteum itself is yellow due to vitamin A, and the term, the label, corpus luteum comes from the Latin word for yellow body. Corpus means body, and luteum means yellow. So if you don't have enough active vitamin A, the corpus luteum is not even a corpus luteum. It is a corpus something else, depending on what color it is. You don't want that. Let's move to the next slide.
You know what? I'm going to stop sharing and just share this window. So, and I should have done this in the beginning. So then I can start muting people and doing things, and you can't see that.
Okay.
All right, go ahead.
All right. So let's look at the complete blood count and iron panel markers in pregnancy. So why are we using pregnancy-specific ranges? We are wanting to reflect physiological changes as they occur in each trimester. Every trimester has nuances in terms of how things change. You want to increase the accuracy of blood work interpretation so that you are giving proper feedback to each patient based on their specific situation and where they are in pregnancy. Better patient outcomes, both physical and mental. I cannot tell you how important it is to reassure someone who is coming from their OBGYN or midwife with a lab report that has flagged their white blood cells, their neutrophils, some of their liver markers, some other stuff as being really off because the lab is using non-pregnancy reference ranges for all of these things. The patient may be really distraught, and their provider may not know that these markers change in this specific way and isn't really able to counsel them, except maybe in very generic terms saying, oh yeah, sometimes white blood count goes up a little bit, but it's not really able to tell them like how much for that trimester of pregnancy. So this might be okay, it may be a problem. So there's a lot of stress and anxiety. Being pregnant has so many sources of anxiety. People are already worried about, what cheese can I eat? And is it okay for me to eat salad? I mean, in a situation like that, do you really want people to be worried about their neutrophil count when it's actually normal and healthy for their trimester of pregnancy? You can reassure them tremendously, and you can hone in just on the specific things that are off, if anything is actually off. So you can reassure them in terms of everything that is okay. And we can really hone in on prevention by looking at subtle markers that are early warning signs of potential problems. So this is incredibly empowering. You get to become the expert, and this will help you build your practice, because there is no better way to build your practice than to be efficacious and to have a solid professional reputation that comes from having excellent patient outcomes and high levels of patient satisfaction. You can help improve the field by ushering in a new norm. Who doesn't want to, who among us who works with clients of reproductive age, and who works with clients who are trying to get pregnant, who are struggling with infertility or a history of miscarriage, who are pregnant, and who have recently delivered a baby. Those of us focusing on this patient population, who doesn't want to usher in a new norm and improve maternal and fetal, maternal and infant outcomes, especially those of us working in underprivileged areas, food deserts, working with underrepresented populations who have gotten the short end of the stick in terms of allopathic care in hospitals and in OBGYN settings. Midwives are doing an amazing job. There are a lot of really proactive OBGYNs as well who are trying to change that paradigm, but working with specific labs can help bring in an increased level of reproductive justice. And this is really important work. It's part of a bigger picture, of course, but it is tremendously impactful. So here are some of the physiological changes in pregnancy. Hemodilution is the best known and most discussed mechanism for differences in pregnancy blood work, but it's not the only one. There are endocrine mechanisms, for example, increased insulin production, hepatic, increased protein production, renal with increased filtration, cardio with increased cardiac output, respiratory with increased ventilation. And some of the mechanisms include maternal, placental, and fetal. So these are really important things to keep in mind. When it comes to areas such as preeclampsia prevention, it is really important to actually be aware that, here, and when you're looking at blood work, by and large, you're looking at maternal, placental, and fetal mechanisms. But in the area of preeclampsia prevention, it is really important to know that there is a paternal contribution to preeclampsia, and partly because the placenta is 50% from the mom and 50% from the dad, and so is the fetus. So there are actually, some paternal mechanisms in the background there affecting the maternal, fetal, and placental behavior in some of these areas. So really fascinating stuff. So there are numerous markers, like Marianne said, that change during pregnancy. This is just a quick summary of these: red blood cells, hemoglobin, hematocrit, mean corpuscular volume, MCH, MCHC, and RDW go down. White blood count, neutrophils, lymphocytes, monocytes, and neutrophil to lymphocyte ratio increase. Fibrinogen, D-dimer, and other coagulation factors, as well as MPV, also increase. Glucose decreases, but insulin and C-peptide actually increase. GFR goes up. BUN, creatinine, and uric acid go down. Sodium, carbon dioxide, albumin, total protein, bilirubin, GGT go down. Alkaline phosphatase and bile acids go down in the first and second trimester, and then up in the third. Alkaline phosphatase also remains elevated during breastfeeding up to 18 months. Cholesterol, LDL, HDL, and triglycerides all go up significantly. In fact, it is uncommon to have a pregnancy-focused provider run a lipid panel during pregnancy for this reason. Iron and ferritin go down. Transferrin, copper, and ceruloplasmin go up. B6, B12, homocysteine, retinol, zinc, calcium, and vitamin D and calcitonin. I'm sorry, what does that mean, Mary?
Yeah, I mean, they all go up and down. It depends.
Okay,
So
yeah.
It was too hard to put arrows in each one.
Okay, great. Great, thanks. Estrogen, progesterone, DHEA, sulfate, prolactin, sex hormone binding globulin, cortisol, and HCG all go up. TSH, total T4, total T3, free T4, free T3, thyroglobulin, thyroglobulin, T3 uptake.
We're going to talk
will
about
be,
that later.
yes.
Yeah.
Yeah, so we will be discussing those soon.
Yeah. I mean, there's also even way more than these. These are all the ones I just thought I'd throw on one slide to show you just at a high level how these all change, and there may be nuances throughout different trimesters that some of these do change, go up or down.
Sure. Yeah. So there are a number of anemia markers on the CBC. Remember, you also want to look at the nutrient markers correlated with the type of anemia that you are suspecting on the basis of what you're seeing on the complete blood count. So some of these markers are red blood count, hemoglobin, hematocrit. And keep in mind, there are huge differences between non-pregnancy and pregnancy trimesters. So for example, if you look at the red blood count in non-pregnancy, we're looking at, if we look at the optimal range in green, 4.1 to 4.8. First trimester of pregnancy, 3.8 to 4.5. Trimester 2, 3.6 to 4.3, and trimester 3, 3.8 to 4.5. So it goes back to the same numbers as the first trimester. So in the second trimester, you have the tightest range there.
Yeah, you'll see on the next slide and why, with the graph on why that happens.
Yeah. Yeah.
And this is, because ranges change at different age groups around the red blood cell related markers, these are just a snapshot of, let's just say like an age 30-year-old, and these are her ranges. But if you had, we have different ranges for ages, in 45 or 50. And so this is just one snapshot. And also these are the ranges for somebody living at sea level or less than 1,000 meters. And they'll be different once they, for people living at a higher elevation.
Yeah, absolutely. Yeah. There are so many different nuances that can affect these factors.
In the course, so we have a table like this for every single grouping of markers that makes sense. And also these are active links that can take you right to the bibliography that I have for my software that back up all these different ranges with different studies. And around the red blood cell, I found studies, all the red blood cell related markers. There were studies that tried to define a healthy population using the NHANES data. And so we use that as our lab reference range to start at a healthy lab range and then take one standard deviation from the mean for the optimal. Otherwise, usually we go with LabCorp or Quest for our lab ranges, whatever. LabCorp is usually a little more accurate and back their stuff up by studies. And then we back our optimal ranges up by studies. I just thought I'd throw that in there.
Yeah, thanks. Yeah, so what is hemodilution? It is also called the physiologic anemia of pregnancy or dilutional anemia. Plasma volume increases in pregnancy because of vasodilation and water retention. Blood samples taken during pregnancy are more diluted with water than non-pregnancy. So look at those two images of the vials, non-pregnant and pregnant. Look at the different composition. There is so much more, there's so much less red in here and so much more of this sort of like plasma volume that is filling the space. So this is why levels of RBCs, hemoglobin, hematocrit, and others on blood tests look lower in pregnancy than in non-pregnancy. Part of that is just an artifact. It's not necessarily anemia. So if you're using non-pregnant ranges to interpret the results that your patient is coming to you with, you're going to suspect anemia even when it's not there. So using the accurate ranges are going to help you notice. Obviously, if you are the type of clinician who can diagnose and treat, then you will be diagnosing and treating actual anemia. If you are a functional, unlicensed practitioner who cannot diagnose and treat, then you are going to be addressing the functional imbalance. So that is the difference. Red blood cells, hemoglobin, and hematocrit reference ranges should be adjusted downward during pregnancy to account for these changes. I'm sorry,
Do you want me to take
can I
over?
ask
Go ahead.
Tina to please turn off your video? I don't know if it's on. So, okay. Vasodilation in pregnancy. We have relaxin, which is a hormone that is secreted by the corpus luteum. It increases during pregnancy, and this causes renal and systemic vasodilation. It protects the mother. Vasodilation protects the mother against late pregnancy hypertension and hemorrhage at delivery, and it results in increased vascular capacity. So one of the reasons why vasodilation helps protect against hypertension is because when you have vasoconstriction, blood pressure tends to go up, and when you have vasodilation, blood pressure tends to go down. You can nonetheless have a patient who has a history of low blood pressure, and maybe their blood pressure is low, and then all of a sudden it goes high. So just because somebody has a history and a pattern of low blood pressure, even during pregnancy itself, does not mean that there's a guarantee that they will not develop gestational hypertension at some point. This is why we want to make sure that every prenatal visit includes a blood pressure reading, no matter what the history and patterns have been so far. Vasodilation can result in increased vascular capacity. Okay. Extravascular space fills with water. So osmolarity is the concentration of solutes in the blood. And plasma osmolarity decreases 6 to 10. I don't really know how to say this, but
milliosmoles per kilogram.
Okay, great. Thank you. So look at the difference between non-pregnancy and pregnancy. It's just amazing how much more liquid there is for the same volume. It's so everything is very much more diluted.
I could take over. We gotta take it up.
Yeah, sure.
Okay. So this is just an example from a study that we've used to show you how between non-pregnant and pregnancy, the vials there, how that plasma volume changes. It starts to increase 6 weeks in, it reaches its peak at 32 weeks. And then it remains stable until delivery. But also the body is making, the bone marrow is making more red blood cells. And you could see how the erythrocyte volume, based on iron or non-iron, how many more red blood cells are also being produced, but it's about 25% the level of non-pregnancy. But because the plasma volume expands up to 50%, it looks like the woman has anemia, but really she is making more red blood cells, not as much as the water is filling up in that vascular system, and that plasma is made up mostly of water, which is why it looks so different there in pregnancy. But when we saw that table, the big, like in the second trimester, is the biggest difference between plasma volume and red blood cells. So red blood cells went down the most in the second trimester because plasma volume then in the third kind of levels off, and production of red blood cells still increases. So we'll show you this in action. So when you apply trimester specific reference ranges to anemia related markers, you could see a difference here. So these are graphs and ranges for a 29-year-old female in the second trimester, and her elevation, let's just say she's less than 1,000 meters, which is 3,281 feet. So she's at sea level somewhere, or a little bit below. But if you don't adjust those ranges for the pregnancy trimesters that she's in, and you use the ranges that are on the lab report, it may look like she has anemia. because you can see here at hemoglobin, let's just look at lab min hemoglobin 11.1. And these markers are even below lab. So, but then if you adjust the reference ranges downward for the second trimester of where they normally should be, then anemia is unlikely. Those ranges move down and the values, go into the optimal range. So now you can see hemoglobin at a lab min at the second trimester is 9.6. Then now, so this is take a different woman, same 29-year-old female in the second trimester, and now, but she lives in Santa Fe, New Mexico. We have 5 different increments of elevations that we adjust reference ranges downward or upward for those different elevations. So if you were to take those second trimester reference ranges at sea level, just like before in the previous slide, the lab min 9.6, it looks like everything is, she may not have anemia. But then if you adjust those reference ranges upward based on her elevation, it does look like she might have anemia. So, and in the software, we don't say anemia, we call it suboptimal blood oxygen delivery. So it's just a process of the red blood cells delivering oxygen to all cells of the body. It's suboptimal. And so, it's below optimal. So there, in this case, if you're not adjusting for trimester and for elevation, you may think somebody doesn't have anemia when they really do. And you can always click on this and it'll take you to the high elevation section in the bibliography to show you the studies that we use for those adjustments. I'll keep going here. So then the immune system, the changes in pregnancy, I didn't know any of this. So when I was researching around the immune system, the neutrophils, who knew, they're key players in tissue and artery remodeling in the placental vascularization during the first and second trimester. So those neutrophils are helping to regulate the development of the placenta, to promote the remodeling of the spiral arteries, the arteries that connect the placenta to the mom, and aid in the successful implantation of that placenta. And it's so fascinating, and of the egg. And so the neutrophils increase significantly throughout pregnancy, and you'll see that here, which then in turn, because neutrophils are one of 5 different white blood cell differentials, that causes the white blood cells to also increase during pregnancy. So here's a table from the course where we show white blood cells increasing 62%, 72%, 89%. And what I do, where I'm getting these percentages, I just take the mean of the range of the optimal and compare it to the mean of the range of in each trimester to the mean of the range in non-pregnancy. So it's an average. So even like if you took the upper end of like neutrophils in the 3rd trimester, it's over 200 and some percent. So you can see how neutrophils increase drastically at first, even throughout pregnancy, 118%, 157%, 171, even more if you're looking at the upper range. And then here's an example, just graphically, see it in action. So if you're comparing absolute neutrophils at 6,000 per microliter in non-pregnancy, that's going to look high. You may think she has some sort of bacterial infection and start treating helping, them to correct that bacterial infection, not treating. Then if you're adjusting those ranges upward to where they should be to reflect each trimester, you're going to see even in the 3rd trimester, 6 might be even a little low. So, but when you adjust those ranges, you're going to give that woman relief to show her that no, you don't have a bacterial infection. That is just the way it's supposed to be. Here's some kidney changes throughout pregnancy. This is really fascinating. The kidneys increase in length and volume, and blood flow through the kidneys increases, and the ureters, that connect the kidneys to the bladder, those increase. So that's why women are always having to urinate, but it's all on purpose because of this. Here, I'll just read this one. Increased kidney volume along with increased water retention from the increased ADH is antidiuretic hormone that increases, and increased pressure on the bladder from the expanding uterus can result in urinary stasis that contributes to the increased susceptibility of UTIs in pregnancy. And this is why you may see a lot of UTIs during pregnancy, because these physiological changes. But this is done on purpose because we want to get rid of these waste products, get all those toxins out of the body so they're not going to the fetus. So what happens, the EGFR that you see on the CMP, that's the glomerular filtration rate, try to say that 5 times, it increases sharply, even in the first 6 to 8 weeks. And then as a result, all those waste products decrease, creatinine, BUN, uric acid. That's so cool. So here's another table. Again, and like you could see BUN, you could see creatinine decreasing, you could see uric acid decreasing, and then you could see EGFR around 90, above 90 in non-pregnancy is a good optimal range for EGFR. But in the first, second, and third trimester, you want it to be 131, above 135, above 117. So if you know, you might want to look at that for a pattern of, there's some issue with kidney filtration, and you don't want that mother to be reabsorbing those toxins, those waste products. Here's an example too, in the graphs where BUN at 11 micrograms per deciliter is no, milligrams, I'm sorry. So if the BUN was 11 in non-pregnancy, using non-pregnancy reference ranges, that may look a little low, but in trimester 1, that BUN should, if you adjust those ranges downward, so you see the lab min for BUN in non-pregnancy is 10, but it should be only around 7 in trimester 1, 3 and 3 in trimester 2 and 3. So then that 11 is going to look a little high, and you look at that and creatinine and uric acid, and if they're all on the higher side, you may know that there's some issues with kidney filtration. And here, this is how you apply them all together. Let's just say a 39-year-old female in the second trimester. If you're using non-pregnant ranges, you're going to think there's no renal dysfunction. She's filtering just fine. But then if you apply those reference ranges that I just showed in the other table, now look at this, EGFR is very low, and all these waste products are on the higher side. I don't have uric acid in here, but if you had a value for it, it would show up in here. But then this is where you want to check blood pressure and check symptoms for preeclampsia, because if you're just reabsorbing those toxins, those are indications that there could be a blood flow issue with blood pressure. And then, so possibly renal dysfunction is possibly likely in that case. So applying the appropriate ranges in each trimester of pregnancy is really important. Thyroid physiology. I don't know if I'll take this, Sarah. I don't know if you or I are taking this, but the thyroid markers fluctuate in a healthy pregnancy, and they're supposed to, because the human gonadotropin that's created from the placenta, it looks similar to the thyroid, to TSH. And so then it stimulates the TSH receptors on the thyroid to make it produce more thyroid hormone. So then total T4 go up, total T3 go up, and TSH goes down dramatically because the HCG is taken over for TSH. And then also estrogen, it stimulates the liver to produce a lot of different hormones. That's why transferrin goes up, fibrinogen goes up, but also the thyroxine binding globulin, the protein that binds to the thyroid hormones in the blood, that goes up. And so because of that going up, you're going to see a lot more T4 and T3 in the blood, because that's what's measured. Total T4 is the one that's measured, that's bound to TBG. And so if you're not adjusting these things, you may think everything looks normal around thyroid physiology, but then you may miss some, hypothyroidism. You want to always, even before in preconception, we talk about, you want to check for thyroid antibodies and get that thyroid under control before even trying to conceive. But you may I keep saying misdiagnose. You may misidentify some things if you're not adjusting these ranges. Same thing here. So then, because that HCG is so high, that you could see TSH in trimester 1 goes down average of 52% over non-pregnant levels. So you really need to adjust those ranges downward for TSH. And you can even see in our lab, or our non-pregnant ranges, our optimal is about 1 to 2. Sometimes people are even saying you could go down to 0.5, but we have a bunch of different studies that back up 1 to 2. And then postpartum. You want to take over this, Sarah?
Yeah, sure. Thanks, Marianne. Um, so during postpartum and lactation, we want to keep in mind the impact of birth, and the impact of medications and C-section delivery if that has occurred, immune changes, hormone changes, liver enzymes, and prolactin. So the postpartum liver um, is it has an interesting pattern in the sense that during the first 5 to 10 days after birth, AST increases by 88%, more or less, ALT by about 147%, and GGT by about 63%. Opioid medications and C-sections are associated with a greater increase in liver enzymes. The immediate postpartum period is not the ideal time to run a liver panel on someone. It just is not going to be that that revelatory in terms of what's actually going on. There can be a lot of confusion. Alkaline phosphatase may remain elevated for up to 18 months in lactating mothers, according to a study that was conducted. This is really important in particular if you have a patient who has a history of some kind of liver condition like, autoimmune hepatitis. It is going to be really important for the healthcare team as a whole to collaborate. So, for example, the hepatologist may be seeing one thing, and then the midwife or holistic nutritional practitioner or naturopathic doctor may be saying, hey, wait a minute, but let's look at these studies that show that alkaline phosphatase could actually remain higher. Let's look at the actual ranges for postpartum so that we're not assuming that there is an active liver dysfunction going on. Let's also look at what's going on with the ALT and the AST once those settle down, starting around week 3 after delivery. So when is the optimal timing to run lab tests, and when should we be alarmed about a flare in this person's autoimmune hepatitis, for example? Yeah. So I'm going to hand this over to Marianne to talk about our 6-week masterclass that we're going to be starting to teach next month.
Yeah, May 9th. Yeah, we're excited about it. I mean, we love teaching this stuff, and there's so much we couldn't fit it all in this webinar. So we just want to let you know that what we have coming up, and we teach for 2 hours every Thursday for 6 weeks, and 90 minutes at least is of instruction, and then we do 30 minutes of Q&A. Sometimes we've even stay on longer to make sure we answer the questions. We record it. We give you the recording, the transcript. We give you a summary. We have AI that summarizes it. We provide the chat information, answer any questions all throughout. And so what you'll learn in the master class is basically in depth of what we just covered in each of those sections: the essential blood markers to run during preconception, pregnancy, and postpartum, the physiological changes that occur in various body systems during pregnancy and postpartum, the impact that these changes have on the blood biomarkers, and then how to apply trimester-specific reference ranges to effectively interpret blood work throughout pregnancy. And so how you'll be able to benefit from this class, you'll be able to quickly and easily distinguish between the the physiological changes of pregnancy and postpartum versus the potential pathology. There's a lot of P's in that sentence. Recognize the problematic patterns that alert you to issues such as preeclampsia and gestational diabetes. So you can be on top of these conditions and help them correct those before they really become a problem. And you'll gain confidence interpreting blood work for your reproductive clients. And Sarah tells me this all the time, reducing anxiety in your pregnant clients caused by the false flags on their lab reports. When a pregnant woman gets their blood work back from LabCorp requests, there's all these highs and lows, and they're always all stressed about them. But when you put them in the software and apply these ranges and adjust them, everything should look normal. If everything is normal, they may fall in the optimal range, and then you give them you relieve that anxiety. So this is the detail of the class we have. So week 1 is an overview more into detailed reference ranges and things on, to consider, and then preconception markers for male and female. And then in week 2, we go in depth on the CBC markers, the iron panel, zinc, and copper markers. Week 3, we do the CMP. The first part is kidney, liver, electrolyte, and protein markers, and how the physiological changes in all of those, and how they change with tables in each one. And then week 4, we do part 2 with glucose. Even though that's in the CMP, we have all these other ones, insulin, C-peptide, cortisol, homocysteine, and then many other ones that we put in here. And then we go week 5, we talk about postpartum markers, how they change, and considerations, like Sarah mentioned, on when to really test postpartum, especially during lactation. And then a whole week on thyroid markers and how, preconception throughout pregnancy and postpartum. And then, so when you sign up for the course, you get the Choose a Perfect Prenatal guidebook that Sarah created, which was really cool on, helping you decide which prenatal vitamin to give your preconception client. Then when to order labs in preconception and pregnancy. So we have tables with the different markers and showing you which ones to order throughout each trimester of pregnancy and preconception. And then this really cool graph that I have of all these different ranges of TSH throughout pregnancy, from lab, different organizations, different thyroid experts, just to show you how much TSH changes. And then also I'm throwing in 2 free months of my software. You can use it all of May and all of June, even though the class starts on the 7th or 9th, I forget, but you can start using it right away, and you can add as many tests as you'd like. And so you can just get a feel for how these ranges change throughout pregnancy, and get a feel for the software. And so then, if you put some client tests in, that you can come to the class with any questions you have on an interpretation, and we will make that part of the course at the end. This is what it looks like. We have, this is what is in there now. We have these is the recordings from the last live class that we did, but you'll get access. And as the recordings come available, we'll have the slides, the summary, the transcript, the chat, and the video from each module. And there's the bonus Perfect Prenatal. That's the when to order labs, graphics, the tables. So that's just an idea of what the course looks like. And this is Amanda. She was in the course last year, and she gave us a really good compliment. Like, this class was highly worthwhile. I already knew functional blood work, but was often stumped when I saw markers that were dramatically different once my client was pregnant, after evaluating her labs for months or years before pregnancy. Marianne and Sarah were incredibly thorough and provided in-depth studies to support their findings. Not only was the blood work information enlightening, I greatly appreciated the extra wisdom they shared about different diets and nutritional philosophies. Sarah, like throughout when she's answering questions, she's bringing all her years of knowledge of what she's seen, what she recommends, and it goes even beyond blood work. So I'm so impressed with these women. I highly recommend it. So, hey everyone, this is Marianne. Thanks for sticking in there for the webinar. I hope you enjoyed it. I wanted to share the website for the course. It's buildnurturerestore.com/class-page-self. And at the website, you'll be able to learn more about the course. And if you're interested, you can click on any of these buttons in here, and it'll take you to the checkout page. I hope you enjoyed it, and if you have any questions, please let me know. Thank you.